So is it audible and visible? Yes. Okay. So welcome students. Let us see in medicine, the respiratory medicine part. What were the questions asked? I have got few recalls. I would be taking your support to frame the questions adequately. So the questions were more testing your basic concepts. So advanced questions were not that greatly given, and more of previous year topics were asked. So what we have done in INICET PYT, there were few direct hits for your exam students. So let us start the discussion. The first question, the following spirometry is suggestive of. Now if you notice, there was some diagram given like this, but the gist is FEC was normal, whereas the FEV1, so this is normal value, this has been significantly decreased. So FEV1 is decreased, FEC is near normal. So what will happen to ratio? Because FEV1 is decreased, FEC you can see here. So in both normal and the patient here, the both are correlating. So FEC can be near normal, whereas FEV1 is significantly decreased. So it is reduced. So whenever the ratio is reduced, what is this referred to as? It is called as obstructive defect. So what are the diseases responsible for obstructive phenomena here? We have bronchiectasis, whereas all these three are happening as a restrictive phenomena. Okay, so even neuromuscular disorder is also restrictive. Even neuromuscular disorder is also restrictive. Chest wall disorder is also restrictive. So this is the algorithm that I discuss generally in my class. Whenever you get any spirometry, just to see the ratio. If the ratio is low, automatically your answer should be obstructive. If ratio is normal or increased, it can be either normal lung or restrictive. So how do you differentiate normal and restrictive? In restrictive, the lung size is reduced. So FEC is less than 80%. So it means lung size is reduced. So if it is obstructive, we do a bronchodilator reversibility test. So if there is reversibility, most probably it is asthma. If it is not reversible as per the criteria, increase in FEV1 more than 12% after SABA inhalation, we consider it as COPD, and also here generally bronchiectasis. So bronchiectasis can also be not significantly reversible. Then restrictive, fibrosis, ILD, occupational lung diseases. So these are intrinsic restrictive lung disease. It means directly your lung parenchyma is shrinking, so it is unable to hold air, or your lung might be healthy. Something outside from your lung is not allowing your lung to expand properly. This phenomena is called as extrinsic restrictive lung disease. So any of this, GBS, polio, myasthenia. See, I am Shrav 45. First of all, you are asking regarding DLCO. So when you are going through spirometry, you should have a practical approach. When you are doing an investigation, always Dr. M. Shrav is not just for exam, even in your practical practice also. make sure in that investigation only you are getting everything sorted out. So if you go on writing investigation, you will not become a good practitioner. No patient will come to you, because spirometry is 500 rupees. DLCO, the investigation itself costs 3,000 to 5,000. If you are able to diagnose by spirometry, it will be sufficient. Still you are having DLCO, I want to write DLCO. In asthma, DLCO can be elevated, but it is in no way diagnostic. In COPD, DLCO is reduced, but it is in no way diagnostic. We are having already a diagnostic investigation. Then what is the fun in writing DLCO? I am a more clinician who take care of patient with minimum cost, maximum benefit. So spirometry, if you are having a good bronchodilate reversibility, patient is doing properly. So asthma, COPD, you can easily differentiate. So if you want to spend more money on the patient, you do DLCO. In asthma, it might be elevated. In COPD, it might be reduced, but it is in no way sensitive or specific. So in ILD, to know the severity of gaseous exchange derangement, you can have a DLCO. So DLCO is not diagnostic there. It will have additional benefit in further monitoring. Then this was another question asked, ATT causing hypothyroidism. I think it must have been discussed in your pharma. So ethionamide and para-aminosalicylic acid generally causes hypothyroidism. So pyrazinamide, usually the specific side effect is hyperuricemia. Cycloserine can have psychiatric disturbances, and bedaquiline, as you know, QT prolongation. So I think this is a straightforward question. So I think most always see here ATT, the pharma part. Pharma part is very, very important. So these side effects, what to do next, these are very, very commonly asked. Then was any question given like this? There is a patient with fever, weight loss, lymph nodes enlarged, and ACE increased. ACE increased. Is there any question like this? So if you see with ACE elevated, one possibility will be sarcoidosis. So if you rule out all other conditions, so always again, this is not the confirmatory test. This is not the confirmatory, but you should have adequate clinical scenario, and generally sarcoidosis is diagnosis of exclusion. So if you see this is not confirmatory, you can suspect possibility of sarcoidosis. So there is no confirmatory test for sarcoidosis. So it is always you have to rule out all other diseases, and there is only sarcoidosis left in your mind. And in the tissue biopsy, you have seen non-caseating granulomas. So then you can think of sarcoidosis. But this will give you a rough idea that this patient might probably have sarcoidosis. So this is not confirmed. I need help from your students. Was any question given in this manner? Yes. Fever, weight loss, lymph node enlargement, ACE has increased. Okay. Then as usual, this is a straightforward question. ABG, pH 7.28, PaCO2 80, bicarb 26. So now let me decode this question. As usual, whenever they give any ABG parameters, even if you don't know anything about ABG, like I tell you in the class, always draw arrow marks. So what are the arrow marks you draw here? pH reduced, PaCO2 increased, bicarbonate is slightly increased or still normal value. So if you consider normal PaCO2 as 40, bicarb 24 or 26, so it is relatively normal. So here or normal or slightly increased. So here the decrease in pH is acidosis, whereas increase in CO2, both are opposite. See, usually the reference value of bicarb 24 to 26. So if they have taken 24, it is slightly increased or it is normal. But CO2 40 is normal, 80 is significantly increased. So increase in CO2 is generally respiratory acidosis. So it rules out respiratory alkalosis. And if at all they have given metabolic acidosis, metabolic alkalosis also, it rules out. because history is not given. We cannot exactly say whether it is acute or chronic, but most probably in a chronic respiratory disorder, because your kidneys have learned how to fight, usually the pH will be near normalized. So generally in chronic respiratory acidosis, if you see, the pH will be 7.33, 7.44. If it is very less than 7.3, generally it has to be a acute respiratory acidosis. So we know that in a respiratory acidosis, how to calculate compensation. If it is acute phenomena, for every 10 mm Hg increase CO2, bicarbonate increases by 1 milliequivalent, because your body has not didn't know how to fight. So here bicarb is taken only 1. So the pH fall cannot be stopped properly. Whereas in chronic, for every 10 mm Hg, for every 10 mm Hg increase in CO2, bicarbonate increases by 4 milliequivalent. If history is not given, how to say whether it is acute or chronic? So usually in chronic, the pH fall will not be that great. So generally, if you consider normal 7.35 to 7.45, if you consider normal as 7.35 to 7.45, so only slight fall of pH will be seen, whereas in acute there will be more significant, because your body doesn't know how to fight. So here, if you apply this rule, considering this as acute, see here, CO2 has increased from 40 to 80 by 40. So for 10 it is 1. To call it as adequate compensation, if you take 26 as normal or 24 as normal, so if you add 4, it must have been at least 30. It has to have been at least 30. So if it would have been at least 30, then COPD means it has to be mostly chronic. So here it is not correlating. So this bicarbonate given and expected are not correlating. So it means it is not having proper compensation. So if it was somewhere 30 in acute or in chronic, so if it has been for 10, it is 4. If it has increased to somewhere with 16, 26 plus 16, somewhere 40 or 42, then you can consider as compensation. So it is respiratory acidosis with inadequate compensation. So this must be the best answer. Now many people ask me this question: sir, what is the reason for inadequate compensation? Now let us see. And second question they ask me is, sir, to call it as adequate compensation, should pH be always normalized? So now let us first see the thing given in Harrison new edition. So they have clearly mentioned, in general with one exception, compensatory responses return the pH towards normal, but not to normal value. So don't think if pH is normalized, only by seeing pH you can say compensation. No, you have to see always given and expected value. So only your body's response will bring the pH to near normal. It cannot completely normalize. Only when there is chronic respiratory alkalosis, when it is prolonged, it is only the exception to this rule. So just by seeing normal pH, don't call it as compensatory phenomena generally. You have to see given and expected. Now if you see here, whenever pH is reduced, CO2 and bicarbonate are increasing. So it is a respiratory acidosis. So then pH is increased, CO2 is decreasing, bicarbonate is decreasing. So we discuss a formula called as ROM, respiratory opposite. So pH with respect to parameters, opposite direction. Whereas metabolic, you can see everything will be in same direction. So this is one way how you can notice whether it is respiratory or metabolic. Primary increase in change in CO2 is respiratory. Primary change in pH is metabolic. Primary change in pH is metabolic. And coming to the terms of mixed disorder, inappropriate compensation, what is used now? So again, Harrison mentions that if the given values and expected values are exceeding the compensation for a simple acid-base disorder, you should generally consider is a mixed disturbance. So previously we were using the terms partial compensation, decompensation, but according to New Harrison, it has been replaced by mixed disorder. So you should think of two diseases. Now let me put it in a very simple way. Now consider this is a normal individual. So acid and base are in balance. Now by chance in this patient, acid has increased significantly up to here. Base should also increase up to here. So it depends upon the compensatory formula. So this is called as adequate compensation. Adequate compensation. This in Harrison is referred to as simple acid-base disorder. So if acid is reaching to this level, base should also reach to this level. So how much base has to increase, you will know by the relevant compensatory formula. Now acid has increased to this level. So this is second scenario. So acid has increased to this level. Now base has started to increase, but it is not reaching to this level. So it was previously here. You see previously base was here. As acid increased, base should come to this level. But base, because of some problem, it has not increased. So it has only slightly increased. So this suggests a mixed acid-base disorder as per New Harrison. So because it has slightly trying to reach the compensation, in old books it is also called as partial compensation. See here, if it has come to this level, it is full compensation. If it is only this, it is called as partial compensation. Whereas this is scenario 2. Coming to scenario 3. In this also, because of some disease, acid has increased. Now what has happened? Base has not at all increased. This is called as decompensated. So these are old terms. Now this has to be replaced whenever there is a appropriate clinical scenario. This has to be called as a mixed disorder. So this is just for your knowledge. So once again, very simple words. If acid has increased to this level, base also should come to this level. But if there is a scenario where there is acid but base has not increased to the expected level, it started to increase, so it is called as partial compensation. Base did not increase at all, it is called as decompensation. But the reason, always body will try to fight and it will try to do adequate compensation. If it is not able to compensate, by seeing the clinical history, you think of any possibility of mixed disorder. Suppose patient is having COPD with diarrhea. Because of diarrhea, bicarbonate will not increase, relevant to patient's what you call CO2. So like that, you have to think of two disorders. So if you treat those both disorders, then only patient pH can be normalized. So this was one question. And there was also students asking me, sir, there was also something called as hypoventilation, hyperventilation. See, always remember, whenever CO2 increase in CO2 in your body is due to hypoventilation. So it happens due to hypoventilation. So whenever CO2 is decreasing in your body, decrease in CO2 generally happens due to hyperventilation. So the reason for CO2 retention is hypoventilation. The reason for CO2 washout is hyperventilation. Now, was there any question given on assessment of severity of pneumonia? So some has given me this recall. Any question given? Yes. Assessment of severity of pneumonia. So any assessment of severity of pneumonia should be done by curve 65. This is the basic score. C for confusion, U for blooduria, R for respiratory rate, B for blood pressure. For each parameter, we give 1 point. So if patient is having more parameters, it means more severe disease. So 65 is age. So this is the basic algorithm. So 0 or 1, it means severity is low or mild pneumonia, home treatment. outpatient treatment. Home treatment means. If it is 2, you have to start admitting in ward. 3 to 5 requires ICU admission. So this is also called as inpatient treatment. So these are the recalls that I have got, about 5 to 6 questions. Any more students? Yes. Any more questions pertaining to respiratory medicine? Any more question pertaining to respiratory medicine? Any other questions? So I'll just wait for another 2 minutes. I will take up your recall. Accordingly, I'll see. So was there any favorite topic to the examiner? Because last few years, examiner will be inclined to one single disease. So I heard that this year also examiner was inclined to few specific topics. In radiology, it was foreign body. In pharmacology, it was anti-tubercular drugs. So curb score was 3. See, the treatment is like this, students. OP treatment and IP treatment. So generally 3 means it can be ward or ICU. So if the patient is sick, here the most important treatment is beta-lactam plus macrolide. The second option, beta-lactam plus fluoroquinolone. So here if he is a ward patient, beta-lactam, macrolide. The second option here is fluoroquinolone. So if beta-lactam with macrolide is not given, so this should be the first option in India. So you can go for second option. So this is always first option, second option, first option, second option. Okay. Yes, students. So beta-lactam common, we have in our ward ceftriaxone, and macrolide common, azithromycin. So here again ceftriaxone, we can give respiratory fluoroquinolone such as levofloxacin. So Thomas Pravin, so the curb score was 3. Can we give fluoroquinolone or see, it has to be always, you cannot give single beta-lactam. It has to be combined with macrolide. And if it was a ward patient, fluoroquinolone. So this is beta-lactam plus macrolide is the best answer if it was given in the options. Yes, pH 7.3, PCO2 60, bicarbonate 28, suggestive of chronic respiratory acidosis. But pH 7.3, 60. So it has to have increased to more. If you take 26, for 40 it is 60. For 20 it will be 8. So the bicarbonate should be at least 34. Or 24 if you take also, bicarbonate should be at least 30 there. So it is a chronic respiratory acidosis, but the compensation is not looking adequate. It must be partial compensation then. If it was 34 or 32, I would have confidently called it as compensatory respiratory acidosis. Yes. Okay, then we will wrap up this session. So any more recalls, and if you want to contact me, so you can send it to my Instagram. This is my Instagram ID. So it was a pleasure always meeting and teaching you students. All the best. So we'll conclude here. Any more, you can directly message me on my Instagram. So this will be my ID. All the very best, students.